One, you are live. Thank you.
Thank you again for joining us today. The premier Black Health Matters New York Summit. We're going to discuss lung cancer now, and African American men have a higher incidence of lung cancer than other racial or ethnic groups, and they have higher death rates from the disease despite having lower exposure to smoking than other groups. According to the American Cancer Society, lung cancer is the leading cause of cancer death among both men, 25%, and women, 20%, followed by breast cancer in women, 18%, and prostate cancer in men. Today, join us with Dr. Paul Paik, who's the clinical director of Thoracic Oncology Service at Memorial Sloan Kettering. He'll speak with us about personalizing cancer treatment for lung cancer. Welcome, Dr. Paul Paik. Thank you so much for joining us.
Thank you, Colin, and the organizers for Black Health Matters for this invitation to come talk about something that's near and dear to my heart, which is lung cancer, but also about community and sort of the impact this has disproportionately in different communities, particularly really in New York City, and we'll get into that in a little bit. It's a big topic, and so what I thought I'd talk about for the next 10 minutes or so is something very specific, which is lung cancer screening, with the idea that if we're going to try to help move the needle on outcomes, on reducing deaths as a result of lung cancer in the African American community, then we've got to start really with lung cancer screening to catch these things early. So as way of overview, I think it's helpful just to talk, and Colin talked about this actually, about how big the problem of lung cancer is in the Black community. We're then going to move on to talk about what the best ways are to partner together to try to improve outcomes in lung cancer, and that'll lead us to the who, what, and why of low-dose CAT scan screening, which is the tool that we use as of 2011. And then we'll touch on a little bit what to do if you're interested in screening and what to do if you've been diagnosed as a next step. So as Colin had mentioned, cancer is the second leading cause of death in African Americans in the United States. So this is just any kind of cancer, which is just a little bit behind heart diseases as the leading cause of death in men and women in the US. So about 20% of all deaths in the African American community are due to some kind of cancer. And this is much higher than we see for really all other causes of death behind that: accidents, strokes, diabetes. Lung cancer is the second most common cancer in African Americans. The most common is prostate cancer in men, which we just heard about from Lou Campbell, and breast cancer in women. But lung cancer is second behind that. And despite the fact that lung cancer is the second most common cause of cancer in the US, it is the leading cause, as Colin had said, of cancer death in Black men and women in the United States, accounting for about 20 to 25% of all deaths. And this is exactly why I'm talking about lung cancer screening, because it is, at the end of the day, a big cause of mortality in the Black community. So your lifetime chance of developing lung cancer, about 5 to 7%, all things being equal. But as we'll see, all things aren't equal. Fortunately, the death rate from lung cancer in the US has gone down pretty dramatically since the 1990s, particularly in men, which is shown in these two diagrams. On the left is lung cancer deaths in men since 1990, divided by African Americans and whites. And you can see that that death rate has gone down quite a bit, and that disparity, that gap in death rate has shrunk also. We think, as we'll see in the next slide, that this is largely related to our success in getting folks to stop smoking. There's been less of an impact in women, again, we think because smoking has been less of an issue in women, but we're making sort of a headway on that also since about 2010, 2005, despite the fact that that is beginning to trend down. That gap is still present, which is something that we're going to have to chip away at also. So this, I love this chart. This shows smoking rates in Black and white men and women since 1965 up to 2017. And it is always amazing to me at how common smoking was back, in the earlier parts of the last century, where Black men and women were smoking at rates of about 35 to 60%, which is a bit lower for white men and women. But that's gone down dramatically, so that the rates of smoking now are around 20% on average in 2017, which is exactly why I think we've seen such a dramatic decrease in death rates from lung cancer, because folks just aren't getting lung cancer in the same rates as they are because they have stopped smoking cigarettes. But of course, there's that still sort of 20% that we got to work on also to get folks to stop smoking. In terms of thinking about ways to help with the curability of the disease, which ultimately leads to decreases in death as it relates to lung cancer, it's helpful to talk a little bit about staging for lung cancer and how that influences curability. So if a lung cancer is caught very early on, so that it's a single tumor in just one lobe of the lung, then it's a stage 1 lung cancer. And the cure rate here is about 75 to 90%. If that tumor is a little bit bigger in that lung, then the cancer stage 2, the cure rate's about 50 to 70%. If it's a stage 3 lung cancer, so the cancer is spread to some lymph nodes in the middle of the chest, then we're looking at cure rates of around 25 to 33%. And if the cancer has spread to a different organ, then that's stage 4 disease, and that really is in general incurable lung cancer. And so it makes sense that if we're going to try to help beat the odds on lung cancer, then we got to pick these cancers up when they're very small, when there's very small stage 1 lung cancers. And the best way to do this, again, is to stop smoking cigarettes so it doesn't happen. And then the other, as we'll see, is to undergo lung cancer screening with annual CAT scans. And the reason why we recommend CAT scans now, as of 2011, and we didn't before that, despite the fact that we had CAT scans available, was because of a big study that was published in 2011 that found that folks who underwent CT screening annually had a 20% decrease in lung cancer related deaths versus those who underwent chest excision. And that was the first study to show that decrease in lung cancer related death, which is why pretty much all major health organizations have picked this up as a recommendation, and which is why we're talking about it today. So who should be screened? In that study, it was men and women who were 55 to 80 years old, so sort of midlife to older. These were folks who had a significant smoking history, at least 30 pack years. And the way to figure that out is you take the number of years you smoke cigarettes and you multiply it by the number of packs per day you might have smoked. So if it's 1 pack a day for 30 years, that's 30 pack years. If it's 2 packs a day for 15 years, that's also 30 pack years. And you have to either be currently smoking or have quit within the past 15 years. And studies have shown, again, that there's survival benefit really in this population. But of course, as Colin was saying, a lot of these lung cancers arise in folks who don't really have a significant smoking history, that are either never smokers or very light smokers. And so we're working on ways to better figure out how to screen these patients for lung cancer in ways that make sense. So what's involved in the CT scan screening? It's a fast 10-minute scan of your lungs at relatively low radiation doses. And so it's not that difficult to undergo from a time perspective and a risk perspective. The report that you end up getting back is a kind of special CAT scan report called a lung RADS report. It sort of helps show in layman language what the CT scan found and what the next step should be that you gotta end up doing. And it could range from just getting another CAT scan in a year's time to getting a scan a bit earlier, maybe getting a different kind of scan, or maybe getting a biopsy as a recommendation. For women who've undergone mammograms, I think you'll be familiar a little bit with that format. There's that BI-RADS report, which you get, which is structured very similarly to the lung RADS report in terms of helping to navigate what to do as a next step. Should everyone undergo a CAT scan if you're in that risk population? And what I'd say is that I think with all screening tests in medicine, the decision-making process has got to be a shared one. It's something that you've got to feel comfortable undergoing, and it's got to make sense for you. And so I think the starting point is the healthcare provider has to make sure that you're in the right risk category for screening. And then you have to have some discussion, I think, about the risks and benefits specifically for you. What's the risk of not doing the screening test? What's the risk of what might happen if the screening test does find something? Because that can be unsettling. There's some psychological factors that I think we've got to take into consideration. There's anxiety that can be provoked because of the CT scan results. And at the end of the day, it may end up leading to a biopsy also. And so what's the risk of undergoing a lung biopsy, particularly if you have other medical conditions that might be present if you've smoked cigarettes. So all of these things are things that I think have to be discussed so that you feel comfortable going forward with that decision to undergo a CAT scan. That said, most of us end up recommending that people who fall within that risk category end up going the annual CT scan route. So I want to take a little bit of an aside, a little bit of a tangent to talk about clinical studies and access in the US, and the fact that African Americans really are underrepresented in the trials that we end up doing. And so I think a good example of this is that study that led to the recommendation for folks to undergo annual CAT scans. If you take a look at that study that had about 53,000 people in it in the US, it's a lot of people for a single study. Only about 4.5% of the population in that study was African American. This in a country that's about 13 to 40% Black, and in a city which is 25% Black for New York City. And I think, you know, the issue here is that it's sort of one of proximity, right? We're not going to know how best to treat folks unless we're actually coming alongside and treating folks. And sort of our studies are not providing adequate access to get folks in within certain demographics, then we're not really going to know potentially the best way to help these folks in screening or in the treatment of their diseases. Colleagues of mine at Longevity, which is a lung cancer advocacy organization in the US, have done a good job presenting some of these data last year. Upal Roy presented this slide, which on the left hand shows a map of the US and what the prevalence of lung cancer is by zip code for African Americans and Asians in 2016. And so you see sort of common areas where there happens to be more lung cancer in these communities. You'll see on the right side a map of where clinical trials are in the US. And it's important to note that clinical trials now are not sort of experimental things. These are really ways to get access early on in drugs that often can make a big difference in folks who have been diagnosed with lung cancer. The issue here is you see big deserts, big patches where there are no clinical trial access, where there is a significant proportion of African Americans who've been diagnosed with lung cancer. And so this gets at the issue, again, of disparity, it gets at the issue of proximity, and it gets at the issue as to why exactly we're talking about this today. And the starting point is discussions like this, is recognizing that the issue exists and is trying to push forward in trying to rectify that. So getting back to screening, what do you do if the screening study finds lung cancer or if you're interested in screening? And the first step is to discuss with your provider for recommendations on oncologists to see in the city. There are many excellent centers in the New York City area, colleagues of mine at the different institutions. It's easy for me to talk about what to do for Memorial since that's where I work. And you just call us. Our website has a great screening quiz at this link that you can click on to see whether or not you should undergo CAT scan screening. You can also call a referral service to get assistance from our nurses as to whether or not you should do that. That referral line also provides access if you're interested in getting a consult here if you've been diagnosed with lung cancer. I'll say also there's another breakout session in the VFairs starting at 12:30, where colleagues of mine will have a Q&A on lung cancer screening and smoking cessation if there are more questions about that. Lung cancer care can, from Memorial, be provided at MSK's Ralph Lauren Cancer Center, which is on 125th Street up in Harlem by Marcus Garvey Park. And of course, we're all down here on the Upper East Side also for the main campus. And the last thing I'll say is there are many lung cancer advocacy organizations that can assist as well that are present in the US. And so I'll leave us with just a couple resources, some sort of posters, again, on smoking cessation and on lung cancer screening that will be presented later on by my colleagues in the breakout session. And I'm happy to answer any kinds of questions you guys have for the time that remains now. There is a question, one question. Again, this is just to invite everyone to attend MSK's virtual exhibition, which is staffed with live representatives to talk more about the resources that are present in our community. There is a question that's just come in. What about those who do not smoke? I have heard you can still have lung cancer. Yeah, this is a big, increasingly a big issue. As the rates of smoking have gone down, we're still seeing a lot of lung cancer being diagnosed, and the proportion of folks who are never smokers or who are collegiate smokers, smoked a little bit in college, for example, but then, quit thereafter, is going up. So about 20% of the most common kind of lung cancers that we diagnose now, non-small cell lung cancers, are from folks who are never smokers. And that sort of gets at the issue of screening in this population. The chance of your developing lung cancer if you're a never smoker is still very, very low, which makes screening difficult, because if we do CAT scans in this population, we're going to have to do a ton of CAT scans, which for the most part are going to end up being negative. And so we're working on better ways to try to help diagnose this in conjunction with CAT scans, understanding, of course, that this remains a big issue. So there's more to come. We recognize that's a big sort of gap that there's present, but something that we can, that there's active research to try to chip away at that. The questions are flowing in now. There's a question about the dangers of radiation from screening. So there is a bit of radiation that's present. The radiation amount is about as much radiation as you get exposed from flying from New York City to California and back. So there is a modest amount of radiation that's present, but in the grand scheme of things, it's quite a small amount of radiation. That is part of the discussion that happens during the screening, though, and there are ways to sort of conceptualize that in terms of just the background radiation we're all exposed to. But that gives you a flavor of what that radiation exposure is, which is fairly modest. The next question is, how does someone learn about clinical trials in lung cancer? Is that something my doctor will tell me about? So I think there are a couple ways to answer that. The first is that hopefully your doctor does, when the time is right, talk about clinical trials that might be available for you that are things that you need to consider. But I think the issue here is part of that map that I showed, that colleagues of ours from Longevity showed, which is that there are these big patches where there are no clinical trials. And the issue here is if there are no clinical trials, people might not realize what clinical trials are available. Longevity, certain organizations have tools to help match folks with clinical trials. There is a kind of not terribly user-friendly national website called clinicaltrials.gov where you can plug in search terms. And then there are other resources to try to figure this out. Patient advocacy groups in Facebook as well that can help you navigate this. So what I'd say is that for trial access, it's sort of there are two things that have to happen in parallel. One is that you should not feel like you can't talk to your doctor about this, like, what clinical trials are there. So I think to kickstart that conversation if it hasn't already happened, and I think this will sort of trigger research on both ends to try to help guide you to a clinical trial if one makes sense. And you can always call different academic centers also to find out if there's a trial that might make sense. There's often a process to help screen folks with that. How many years do you need to stop smoking to prevent lung cancer is the next question, which is great. So the idea is that the risk of lung cancer developing really drops off, not linearly, but somewhat exponentially, but never approaches that point where your risk is the same as a never smoker. This is in part why that 15-year cutoff was chosen, because the risk begins to decrease with how long it's been since you stopped smoking. And so that's why that cutoff is present. But again, that cutoff is somewhat arbitrary. And this gets again at this question of, how do we best screen folks even beyond that, And that can be a one-on-one conversation with your doctor as to whether or not to undergo a CAT scan. But at the end of the day, there's more work that we need to do on our end in the academic community to figure out better ways to more precisely screen folks for lung cancer who don't fit within that relatively narrow segment of the population that this study started. How different is this from a regular CT scan? Will it be as sensitive? So it's as sensitive. The radiation dose is a bit lower, but it's sort of a sensitive enough CAT scan to end up providing the information that we need to make that diagnosis about the nodules. So sort of there's a big, if you think about kind of like an iceberg, the scan results is sort of the tip of the iceberg, but there's a big part that's under the water that's not visible that radiologists in particular are working on in terms of utilizing information from that scan to predict whether or not something is malignant. So there's this sort of big work that's being done and that's been done utilizing this lower dose CT scan to figure out features of the findings that are there to make that categorization in that lung RADS report. Is there a link between lung cancer and smoking marijuana? You know, we really don't have a good handle on that at the end of the day. My own answer to this is from an empiric, I think, absolute standpoint. We don't really know. You know, I think we need larger studies really at the end of the day, retrospectively, to figure out exactly what the impact is, what that link is. And that's just very difficult to do, in part because we don't have really good record keeping. Another good example would be secondhand smoke, and that's maybe a more common question that arises in folks who may have, oh, sorry, let me finish this question. Time's up apparently. But the answer is that we don't have very good record keeping, and so because of that, we can't really get a good handle on this. So again, it's another active area of research, but that really depends on the quality of the record keeping that we have. I'm sorry, there are a bunch of other questions, but we just don't have time to go through these. There is that breakout session at 12:30 though. So I appreciate everyone for attending, and have a good rest of the fair. Thank you.